Okay, so this is for Dr. Parashar. Since I didn't really read the slides, I mean, this is the first time I'm just trying to present for the sake of him. Heavy smoker, we know that, okay. Operable. An interval increase in size, irregular right upper lobe nodule with surrounding architectural distortion, primary lung malignancy. And then this patient got a PET. PET showed FDGA with right upper lobe nodule. Well, the left lower one is not FDGA with, and multiple sub-centimeter pulmonary nodule bilaterally, below the resolution. Of course, the patient's got a CT-guided biopsy, and IR puts in the needle. The pathology showed adenocarcinoma considered from origin from the lung. The tumor is 1.0 centimeter, and then patient doesn't want surgery. Still, Dr. Matisse can correct me, the standard of care is still surgery for this peripherally located early stage lung cancer. And if you don't treat, the survival is less than a year. But apparently this patient opted for not going for surgery, got the SABR, which is stereotactic ablative radiation therapy, which is the same with SBRT, just different name. SABR is cooler because I think that's resembling like Star Wars or the lightsaber stuff. So you can hear this word again and again in the lung world. So the patient got the 48 grade in 4 fractions, 4 treatments. So as we mentioned, surgery number 1, we have lobectomy and segmentectomy, wedge resection, which Dr. Matisse mentioned a little bit about. And then there's radiation with the stereotactic SABR, whatever, and then the fractionated old school radiation therapy, and then observation. Observation means like the patient's probably not going to make it beyond 12 months. And then on the right, you can see the chart from medically operable, borderline, inoperable. And then sometimes surgeons just don't want to operate. I don't know why. And then you just, leave them alone. But so the surgical series can show you that the outcomes, which is from lobectomy, the survival is very nice for 5 years follow-up. So you can see an average of at least around 70, sometimes 80% patients still alive by doing early surgery for early stage lung cancer. And this is the local recurrence rate. When you do a lobectomy, which is taking a lot of lung, which Dr. Matisse knows, and then the local failure rate is really low, it's under 10%. And here it comes that when do you choose between radiation versus surgery? Because number 1, the problem is you're talking about 2 groups of patients. When the patients refer to us, that means surgeons don't want them anymore. So technically, that patient is sick enough. So you're dealing with a healthy group versus a non-healthy group to start with. So if you compare survival, are we comparing, apples to apples or apples to oranges? We don't know. This is the data that show the overall survival. So the higher stage you have, the worse survival you are, from 70, 60 to 46, 38. So this is the ballpark number. And then for SBRT, which is stereotactic radiation therapy, which can either be done by CyberKnife or TrueBeam or TOMO, I mean, the number here is about 50%, 35%-ish, which is kind of mixed at this moment because you can see more and more data later. This is another one for the medically inoperable stuff. So the follow-up is about 30 months. You have stereotactic local failure rate about 4% versus 20% for wedge resection, which is, wedge is about 3 times more than lobectomy when you come to local control rate. Overall survival, stereotactic is lower, but again, are we comparing the same group of patients? We don't know. And this is another part of the local control data and overall survival data. So for the operable patient, and this is the number for surgery, and you can have 56% at 3 years and about 50% at 5 years. And then this comes to that when you have medically operable patients, they live longer because I think it's because of the overall health status. And then in this group, when you separate them between operable versus inoperable, the inoperable patients live shorter, but this is the exact patient who got SBRT. So is that radiation is bad or the patient is bad? We don't know. So that's why we have to go more and more about it. And this is how this radiation therapy came into place. Before, we were treating with 6 weeks, daily, about 50, 60 gray, and patient come here every day. You tell them radiation is fine. Patient finished radiation but didn't work that well. It is because they didn't get enough radiation. When you use stereotactic technique, which BED is called bioequivalent overdose, that means the dose accumulated is more than 100. Once you pass that mark, you can see a drastic difference that the effect from radiation just picked up. So that forms the basis why you need stereotactic for early stage lung cancer. So the traditional fractionated thing is out of picture now. And this is still coming to the medically operable patients for SBRT. Again, this is very tricky because number one, it can be done in a really global manner because once a surgeon finds out it's really easy to operate, it's highly unlikely surgeons will be kind enough to play the patient to radiation oncologist because, and then once you have this group of patients, they didn't get surgery, got radiation more than 100 with stereotactic technique, it will show you no chemo. It will show you a good local control rate, about 86.7% at 5 years, so the tumor didn't come back. And then the survival is around 70%, which is, now you're seeing about 20% difference because of the patients to start with, they're operable. And this is approaching lobectomy data. But is that as good as a lobectomy? Probably not. But that I can show you that in selected group of patients that stereotactic radiation, if we give enough time and volume, maybe we can tell you in 3 to 5 years it's not inferior to surgery. That's the conclusion so far. This is a comparison of the same group of patients survival rate with surgery and radiation. So 76%, 64% still alive. And then it comes to cost effectiveness. This is the, so it says that lobectomy was the cost-effective treatment option in the base case, which I have no idea, but this is data from Dr. Parashar. And then SBRT was nearly always the most cost-effective treatment strategy with stage 1. CODZ lobectomy, okay. So in the medically operable patients, I'm sorry, I have to figure out what's CO and what's MO. I apologize for that. With CO disease, it's very important. I'm have to come back to you and send you an email to follow up. I have to figure out what's that. So there are 5 treatment strategies: lobectomy 59%, sublobar 12%, and SABR is only getting 1%. So, but again, this is the data from 2001 to 2007, when at that time SABR was not really an option. So the number for SABR just pick up in the past 5 years because more and more people find out that SABR is a very useful technique. This is the comparative effectiveness propensity matching. So you can see that I see lots of overlaps, and overall survival, of course, lobectomy is better, and lung cancer specific survival, lobectomy is better. And overall survival is almost the same, which, well, for SABR is sublobar, which is always the same. So if you think about doing a wedge or sigmoidectomy, SABR can be considered as an option. And then for specific survival, as long as you're not doing a lobectomy, these 2 things are pretty much the same. It comes to SABR with the vast lobectomy, and of course the data is going to show you this is still inferior at this moment. Retrospective for operable stage. Again, this number looks fantastic for local control. Is that they fruit pick the patients, or because of the technique, we have no idea, but it comes to a local control rate more than 90%, and overall survival is kind of mixed data, but I will roughly put it between around 70%-ish. So for the patients who can still be operable, it still remains an option only if the patient doesn't want it. But otherwise, I think they still need to get surgery from thoracic surgeons. What those? For radiation oncology, there's the thing that we can pretty much cure every tumor with enough radiation. The price we pay is that we're probably going to kill lots of patients because there's a limit for the tissue around the lung. So if you dump in lots of radiation, toxicity is going to develop. So when we have more than 100, we have to treat the BED. People think about different fractionation regimens, which the goal is that to cure the cancer as much as possible and keep the patient safe. So all these regimens are being studied for the sake of to see which one works better. And this slide is showing you the less radiation you get. When you have less than 105 gray, you have a higher chance of local failure. So the more radiation you give, the more likely you're going to control the tumor. For centrally located lung cancers, so this was called a no-fly zone or non-flying zone, whatever, because in the beginning, when people started this technique, when you radiate the centrally located tumor, you find out patient develop lots of toxicities, like trachea necrosis, hemoptysis, and then somebody got the pencil, drew a circle around the trachea tree about 2 centimeter diameter and said, this is a no-fly zone, forget about it. And later, more and more studies are developed to see if we can still do that. We should have lots of fractionation regimens, but we use a little bit more moderate fractionation, 10 gray times 5, versus on the peripheral lesions, you can do 18 gray times 3, but this is milder and technically it can decrease the chance of developing all these toxicities. And then this is dose escalation trial. We have to find out how high we can go in the centrally located tumor. But remember, anything that's centrally located poses a challenge for radiation oncologists. And there you go. So the peripheral lesions, about proportion without toxicity, about 90, 80%. And then when you go to see the other curve, which goes down even below 50%, that's centrally located lesions. Lately, there's a radiation oncologist, Joey Chang from MD Anderson, who, I don't know how he got it. He teamed up with a surgeon, and he managed to get all these surgically operable patients under his belt and started to treat with radiation. And in that paper, his data suggested these two things are the same. So he kind of presented in a manner that favors us, but because he's a radiation oncologist. He started all this stuff and he put all this data together, and then of course there's a slow accrual because obvious reason that once a patient is operable, you know. So there are two arms. One is sublobar resection versus minus plus brachytherapy. The other one is stereotactic, and this is closed. And they only got 420 patients. That's a lot, and so this is showing two the other trials, which they include different kind of patients. And this is how the trials were run. But I'm just giving you the data that it's pretty much saying that these two are almost the same. It shows that on this curve, this two is actually overlapping a little bit. And for the overall survival, which I'm still suspicious because they see a difference, but this is the only his data, and we are showing you all this data that it was shown to be inferior. So what I can tell is that there's something saying that SABR is pretty much equivalent to lobectomy, but at this moment, I think the safest conclusion to draw is non-inferior to surgery. They're just showing these two things are pretty much the same. RTOG showing that overall survival for two different manners of radiation. One is giving one shot 34 gray times 1. The other one is the fractionated 4 shots, and it's showing that the overall survival is the same. So technically, some places only doing one radiation, just like a surgery. And then people, of course, like brain tumors, they're saying, why don't we radiate first and then try to take it out surgically? And then there's a attempt for phase 1 that you can give stereotactic followed by surgery, because this way that you pretty much minimize the risk of getting a positive margin. And then there's more and more stuff showing that, that's going at Cornell at this moment. And there are some novel agents concurrent with radiation. We see this all the time because this is the age where you got some checkpoint inhibitors, novel agents, people are gonna get this stuff, try to combine with SBRT and try in different body size. So this is the trend. That's how the trial was designed. And this is one of the immunotherapies that Dr. Cameron was proving about the liver in the beginning. So anti-PD-1 without radiation, and that they're seeing that if you give it that pre-operatively, if that helps with survival. So the two arms is that one with the anti-PD-1 alone, two concurrent with SBRT followed by surgery, and then gives them adjuvantly. So conclusions. Surgery is still the gold standard for operable patients. Of course, patients will ask for that. So there's a very interesting thing that one day we had a patient that with really low FEV1, and then the patient was okay. So what happened is that when the patient was doing the exam, it didn't get inhaled completely and then exhaled. So the numbers didn't look that great, but it's now the patient, is the test, how the test was done. So for me, I just let them run the stairs and see how it works. To me, it's very easy, cardio and pulmonary test, and I believe that more than whatever I see. But we do see lots of sick patients that you can think about SBRT. Number two, for the patients who can be operable or marginally operable, SBRT is an excellent alternative, which is true because if you think about the morbidity from surgery, and SBRT is relatively safe in that sense. And the randomized trials have failed because of various reasons, and this is very polite, patients and surgeons. So there are two, so there are multiple things that you can think of. And one thing that from the practice is that if you have a patient with interstitial fibrosis of the lung, doing stereotactic is very risky because of the toxicity to the lungs. So that's something that we have to be considerate. This is the end of the slides.